we have Erik Mertens, who's going to talk to us about a very, very important topic. How do I introduce trifocals in my practice? And obviously, you're going to give your own perspective on this. Amazing.
Thank you, Ashwin, and thanks for the organizer for inviting me. I'm very thrilled to be in India for the third time, and I was submerged in Indian culture a couple of days, and I must say I like it very much. But back to my topic, introducing trifocals in the practice is not as easy as you could think. So I will try to explain to you how I did it and how you can do it yourself, introducing it successful into your practice. This is my financial disclosure. So first of all, what is very important is the power of the patient experience, because this will make you stand out to your competitors. So this is a Harvard Business Review, which was published a couple of years ago, and it was a publication about how to rate your customer experience with your company. So there were 5 levels. Level 1 is unacceptable, up to level 5, which is excellent. And in this review, they asked the CEOs of a company what they thought their customers were rating their company. And then it was asked to the customers by themselves. So look what happened, look what they found out. So 80% of the CEOs, they thought like that their companies were rated as excellent, so 5 out of 5. But in reality, how many customers do you think were rating also an excellent customer service? It was only 8%. So there is a big gap between what you think your customers or your patient think about your company or your eye clinic and what in reality is perceived as excellent is not the same as you perceive it. So customer satisfaction is not the same thing as customer experience. So there are different levels and different things you have to understand. So customer service is understanding the need of your customers and providing adequate advice and assistance. Then you have customer satisfaction. So patients come in for trifocal IOL implantation, so full range of focus implantation, and they're very satisfied with their result. But it does not mean that the customer experience is at the same level, because customer experience means how do customers, patients perceive the whole experience in your practice, from the ringing your clinic for an appointment, dealing with the reception desk, and so on and so on. So customer satisfaction is not the same as customer experience. Because in medicine, patients do not judge the doctor by the skills and his instruments, because all patients think you are a very good doctor, because otherwise they do not come to you. So first of all, they all think that you deliver a very good results, but they have no way of evaluating these factors. Instead, they judge you based on their perception of quality, using other attributes as proxies. So when you're introducing full range of focus, so these advanced IOLs to get rid of glasses, you have to change your practice mindset from pathology to performance. So what does that mean? And words matter when talking to patients. Words matter because they are not accustomed to what we use in medicine as our terminology. So instead, we perform lens replacement surgery, but we do it not only for cataract, we do it for dysfunctional lens syndrome, we do it for refractive error, we do it for lens instability, for IOL-related problems, of combinations of all of the above. So when a patient enters my practice, what do we do first? The first step is realizing that each patient is unique. We have to listen to them. We have to listen to their lifestyle. What do they want? What is their work? What are their hobbies? What do we have to deal with their frustrations and their motivations regarding their vision? So you see here 3 ladies, 3 magnificent ladies, and each of these women, they will having refractive surgery. One of them just happens to have cataracts. So we don't ask those patients, what's the matter with you? We ask them, what matters to you? So it's a completely different communication style, which resonates very, very good with your patients. What is the second step? perform all examinations at the same time, so at the same visit, before giving advice. Meaning, what we do a lens replacement workup, we do all of those measurements, biometry, ocular surface workup, and so on. So step by step, you evaluate the whole eye at once. Step 3 is you talked with the patient about their lifestyle, what their frustrations are, what they want to achieve after the surgery, and then you decide what is medically acceptable, which lens are you going to implant. This is the third step, and what is very important, that when patients come into your practice, that you downsell, not upsell. What does that mean? In our practice, in my practice, all patients are candidates for trifocal IOL implantation until proven otherwise. So we have one fixed price for this premium IOL category, and regardless of when they need a dry eye evaluation or dry eye treatments, we even supply them with omega-3 supplements if necessary, free of charge. Unless it's proven otherwise, we downsell to EDOF or monofocal plus lenses. For instance, when they have advanced glaucoma or when they have a macular pucker or so on, we first refer them to our glaucoma specialist or our retina specialist, and we ask them for advice before we giving an advice of the IOL to implant it. So this is very important, downsell, not upsell, because when you upsell, you advertise with low prices. They come in your practice, say, oh, you need to have a dry eye treatment, oh, it costs you that amount of money, or oh, you need an astigmatism correction, it's an extra charge, oh, you want to get rid of glass, an extra charge. The patients, and imagine when you go for services somewhere else, and they're trying to sell you more and more, so a higher price, you feel uncomfortable. Our patients also feel uncomfortable when you try to upsell procedures instead of downselling. Once you have established all those 3 steps, you go for the step 4, which is you make a specific recommendation for the outcome. So one specific recommendation. The more possibilities you give your patients, the more they start to doubt, and the less likely they will book you for the surgery. So just one recommendation, what fits them the best. So what are the key takeaways of my message here? So that your perspective is not the patient's perspective. As I showed, 80% of the CEOs, they thought they were excellent, 80% of their customers thought they were excellent. So good patient satisfaction is not the same as a good patient experience. And this is all about the patients. It's not about you. So listen to your patients, know what they want, know what their hobbies are and their expectation after surgery. Because they know themselves better than, let me get rid of this one, better than anyone else. Don't give options between lenses, only one option after listening to the patient, after doing all the refractive workout. And you have to be the guide. You have to guide them by the hand so they feel just treated well by you, so to have a personal best vision solution outcomes. Now, with what kind of strategy do we treat our patients to correct them with a full range of vision IOL and to get rid of glasses? So I want to introduce a new strategy with full range of vision, and for this I use the Vivi Next Geometric Trifocal IOL family for a couple of reasons. So this is based on the Vivinex platform, which is a proven platform with monofocal IOLs. It is a very unique set of lenses. It is not apodized. It has a 3.5 diopter near add and a 1.75 intermediate add, and there's also a toric option available. It is fully proloaded with a multi-cert injector. You have different options with that injector. You can have a push option or a screw option to your discretion, and also the nozzle, you can extend the nozzle so you can deliver the IOL into the bag, or you can retract so you have a very small nozzle into the incision of the cornea. So for those surgeons who do not want to enter the anterior chamber further than that. Now, there are 2 lenses in that family. We have the Geometric and the Geometric Plus. Very important to know that the distribution is the same across intermediate, distance, and near. Only the light distribution is a little bit different. So the geometric brings the energy distribution for distance is more than for intermediate and near, and the geometric plus gives more light distribution to the near focus. So here you can see this when you have the Vivinet geometric on the top here. This excellent far vision when you implant it in both eyes. It gives very good intermediate and good near vision. The geometric plus with the light distribution more towards near gives an excellent near vision with a good intermediate and a very good distance vision. So this is the multi-cert injector again. So my nurse is preparing it on your right-hand side. So this is, in my opinion, the best preloaded combination ever. The lens is delivered in a very safe way and in a controlled way. As you can see, I guide it with my left hand with the second instrument, injecting it into the eye. And as you can see, the haptics are delivered slowly into the bag. So, and what about the pairing strategy? So I talked about the geometric in both eyes, I talked about geometric plus in both eyes. But what you do in most cases is I pair those two lenses. Why do I do it? Because while pairing it, it gives me not only excellent vision for distance, but also for intermediate and near. So I will show you here the distribution of the light. I told you here the light distribution is different for distance. More light goes in the geometric IOL for distance and less light for near. And on the contrast, the geometric plus gives a higher energy distribution for near than for far. So what does this give us in real life? And this is the NINO study. This was done by Professor Kaimak in Düsseldorf, and this was published in Clinical Ophthalmology last year. By combining Vivinex geometric in both eyes, it gave excellent distance vision, but less near vision. By giving both eyes the Vivinex geometric plus, it delivered very good near, but less far vision and less intermediate. And what he found out, that 84% of eyes giving the pairing, the geometric and geometric plus in both eyes, that they were within half a diopter and giving an excellent result. Here is the binocular defocus curve 4 to 6 months postoperatively. As you can see, by combining those lenses, it's excellent distance vision, as good as both eyes the geometric. The intermediate, when you combine the geometric plus with geometric, it gives a very good intermediate, a little bit less than both eyes geometric, but still very good. And for near, it gives the same as the geometric plus in both eyes. Here is the subjective patient feedback on spectacle usage. You can see by pairing the geometric with the geometric plus, it gives excellent results for distant, intermediate, and near. Why is this different than mix and match? Because these lenses, they have the same refractive index, so there is no difference in between the two eyes when you mix and match IOLs. It has the same chromatic aberration. It has the same haptics, so it has the same behavior in the capsular bag than when doing mix and match and using different lenses. So the NINO studies concludes that the geometric and the geometric plus trifocals may be used bilaterally or in paired contralateral fashion to provide effective correction of presbyopia. Binocular visual acuity is excellent at all distances. In these 3 study groups, the mean values were above 0.15 logMAR, from half a diopter to minus 3.5 diopter of defocus. And the concept of pairing light distribution profiles and add powers ensures a continuous range of vision from far to near. Pairing those two lenses is the most balanced combination for the highest spectacle independence at all distances. And on conclusion, we can say that every patient in my practice is a candidate for full range of vision IOLs until proven otherwise. So downsell, not upsell, if you want to be successful in this category. Concentrate on who the practice serves and why, and not talk about sickness or disease, but about performance. Prepare the eye for high performance IOLs. What do I mean by that? So prepare the surface of the cornea to make sure that there is no dry eye, because you will end up with wrong IOL calculation, and you have to be within half a diopter of sphere and half a diopter of astigmatism correction after surgery. The geometric pairing combines two identical profiles and is much more favorable than doing a mix and match procedure. There's no need to identify the dominant eye. You can put the geometric plus in the dominant eye or the geometric. The results are the same, as also proven by the NINO study. And it gives, because the center of this lens has a diffractive profile, the rest is a refractive profile. So in dim light conditions, and the pupil dilates, there are less dysphotopsia and a good contrast sensitivity. So I thank you very much for your kind attention.
Awesome. Thank you, Erik. I have one question, and we'll call it a close because I think we have a next session after this. But the question is, in trifocal torics, how important is, there's always a margin of error that you can go off axis 5-10 degrees if it's non-trifocal. But in a trifocal toric, how does that play a difference? Have you had... if it goes off axis by 5-7 degrees, does it make a difference?
Yes, it makes a big difference because every 3 degrees you lose 10% of your astigmatism correction. So meaning when you have 10 degrees off axis, you lose 30%. So it's very important that you align these lenses perfectly in a good axis. That's another importance of treating dry eye before surgery. Because when you're doing the measurement with your biometer or with a topography device or an anterior segment OCT, you will end up with different axes. And when you do not treat and optimize your ocular surface, you will think your toric alignment will be in the right axis, but it will be off axis, and you will end up with worse results.
And any tips for how do you get centration and how do you get toric reduction in stability?
Well, the thing is that you have to, or you mark the horizontal axis. Me in my practice, I always use a femtosecond laser to mark in the cornea their exact axis, and on top of that, my microscope is equipped with a toric alignment system, so I have two systems to align the IOL in the right axis. On top of that, it's very important to remove all the viscoelastic from behind the IOL, so it sticks to the posterior capsule, and it remains there as well. And of course, you need to use a proven toric IOL platform like the Vivinex, which is proven for many years.
Awesome. Thank you so much. And we're going to call a close for this session, but thank you, Erik. This was also the keynote address, so big round of applause for Erik.